can record the meeting, so okay.
It's being recorded.
Okay, so let's start, no?
Okay.
Okay, if we start now?
Sure.
Okay, Professor Kleinman, it is a great pleasure to have you in our seminar on the anthropological perspective on the COVID pandemic. We are very grateful to you to join with us and to share your knowledge on the topics we are going to talk about. I'm immediately leaving the floor to my friend and colleague, Giovanni Pizza, the director of our journal, which has already published some of your articles, and give you a very welcome greeting. Gianni, you have the floor. Go ahead, present our very important guest today, and then you can manage to moderate the debate later.
Thank you
very much, Professor Klein. Thank you, everybody, for meeting us.
Thank you very much, Alessandro. Grazie, Alessandro, for having chosen me in the service idea to introduce Professor Kleinman, and thanks again, Professor Kleinman, for having accepted such an invitation. It was very nice. I have my microphone active. These technical devices are quite devil issues anyway. Anyway, thank you very much, Professor Kleinman, for having accepted our invitation. And probably you know that our society, La Società Italiana di Antropologia Medica, was the first one, the first anthropological society to be founded in Italy by Tullio Seppilli.
Yes.
Of course, I also say thank you to everybody. It's great to meet everybody on such a platform, even if digital one, but digital and digital reality is in this period the way to get in touch, to keep in touch, is very important. Could you please close your microphone?
There is somebody with...
Yeah, maybe they can mute.
I don't know why I can understand. Anyway.
Maybe Maria Ludovica or somebody else has not switched off his microphone. They should.
Okay, thank you very much. Anyway, it is not, of course, due to introduce Arthur Kleinman. He's very famous all over the world as one of the most influential figures in medical anthropology today. And so it's not my task to introduce you. Please accept this, because you are very, very familiar to all of us as a master of thought in this field. Even notwithstanding your age, which is really not too much, indeed, very, very high. It is you are a young scholar, in my opinion. And let me only say that it is very important that in more than 50 years, you taught to many scholars in the field of medical anthropology. You taught to many medical students. You was a supervisor of so many PhD theses in this field. And this is very important because you have been the master of all of us, for instance, but also directly of many scholars, different generations. This is very important, and thank you very much for having entered the field of medical science, because I think that medical anthropology has the great task to break this wall between human science and science. You know, they say science, but they are not anti-human science, so it's quite a necessity nowadays, still a necessity, and this is uncomfortable, but in a sense nowadays is an urgent issue to make a sort of communication, a consilience between anthropology and social science and medical science.
Yes.
You did so much in this field, and thank you very much. I will not introduce you anymore because everybody knows your works, and so I give you the word to introduce your talk, to give your talk. And I just want to add one thing. On my reading, the title of your talk, the keyword is failure. What is this failure of US medical care system, healthcare system. This failure is a very interesting issue from the point of view of political anthropology of health, and I think that you can give us the answers we are waiting for. Thank you very much, Mr. Kleinman.
Well, thank you all for inviting me. I appreciate it very much. And you know, I started in this field as a young man in 1970, a little before that even, and now I'm finishing up as an old man. But I published in the fall of 2019 a book that is the basis for my understanding of the chronic care system in America as having failed. And that book is called The Soul of Care, was published by Penguin Publishers and in the United States. And it's coming out in the UK very shortly, and has already been published in China, Japan, and Korea. So that'll be part of my understanding of what's happening. Now, my understanding of the chronic care system in the United States comes in part then from research that I've done over a long period of time, in part from having been a practitioner, a psychiatrist, and in part from my own experience, personal experience, of having for a decade taken care of my late wife, Joan Kleinman, who had early onset Alzheimer's disease and died in 2011 with that problem. And during that decade, I had many, many experiences of the difficulties of family care and of care for patients with chronic illness and disability. So I was, in a sense, prepared when the COVID-19 epidemic began to watch how it affected and illustrated what was happening to the American healthcare system. And that's what I will talk about, that chronic care system. So to begin with, in the United States, you know, we don't have a national health system. We have a chaotic system that is particularly oriented to high technology acute care. It's very expensive. It leaves out perhaps as many as 40 million people who don't have the proper health insurance. And the very way that we do health insurance indicates the problem, that we don't do it as a human right or as part of the federal government's handling of our lives. We do it through employment. So you get your health insurance in America through your employment. When people turn off their microphones, I think I can get across better. So when COVID came along to the United States, we saw a number of things. We saw, for example, that there was a political failure of attending to a problem that the Chinese, in a sense, gave us 2 months of possibility of developing our own preparedness at a higher level. But we wasted those 2 months because of a failure of leadership and government. Trump, you'll remember, at first said it won't affect us, it'll go away, it'll be a very small thing. And he did very, very little. The only thing he really did was that fairly late, he stopped travel from China. But by that time, actually, COVID came to the United States, not from China, but also from Europe. And it came into a system that was entirely unprepared. So that we saw a breakdown in just simple things, like the availability of gowns, masks, other personal protective equipment in some of the main hospitals in the United States. So this was not at first an issue in poor parts of the United States or at the beginning or in underdeveloped parts. It affected some of the most developed and richest parts of the United States, and they were unprepared. And New York City became a hotspot, as did the New York metropolitan area, as did Boston, where I'm in Cambridge, which is a suburb of Boston. And the initial story was the failure of preparedness. And then, as COVID marched ahead, in the United States, as it has all over the world, it made legible deep problems, our failure to have an integrated healthcare system available to all. So the great effect of COVID has been on marginal populations, African Americans, Latino Americans, Latinx Americans, poor Americans, the elderly, all of those sectors where we have huge problems in the United States of social inequalities being associated with health inequalities, what in medical anthropology we call structural violence, they were all deeply affected. But even in our in wealthy settings, the chronic care system failed. And so here's what I mean by that. And if you look at COVID deaths in the United States, about a third to half, depending on where you are in the United States, occur in people who are over 65 years of age. And the highest rate are those who are over 80 years of age. And if you just think for a moment, it's people who are over 65 years of age who have the burden, the biggest burden of chronic illness. So if you look at people in America who are 65 years of age, they average one chronic illness a person. By the time you're 85 in America, you average 3 to 4 chronic illnesses a person. And these are common chronic illnesses: high blood pressure, asthma, diabetes, cancer, chronic pulmonary disorders, depression, dementia. And these disorders put you at higher risk for death anyway, independent of COVID. So if we take them with age, we have in America what we used to call the old man's friend, which was how elderly men and women, particularly men, died. They usually died from pneumonia, usually a bacterial pneumonia, on top of a chronic illness. We call that acute on chronic. And actually, that's what COVID has done and replaced bacterial pneumonia as killing men and women who are in their 80s, particularly, also in their 70s, who have chronic illnesses or immune deficiency, etc. And it's the breakdown of our system for caring for those chronic illnesses that place these people already at high risk for COVID. So for example, if you look at my state, Massachusetts, One of the hotspots in Massachusetts was the home for veterans in Boston, which is an elder care facility in which I think it's somewhere between 70 and 90 veterans died of COVID in this facility. And there was, if you look at the causes of death, we just had a report came out, I think, yesterday on this. Those causes of death were due to the inadequate infection control. And so when this, just to give you a sense of how terrible is the chronic care system in America, in this nursing home, this home for soldiers, they decided at some point in April that their staff was not sufficient and that they had so many people infected with coronavirus that they closed off a part of the facility and mixed coronavirus patients together with those who didn't have it in the other part of the facility to make it easier for staff to work. And the outcome was that everyone became infected, not just the patients in that facility, but also the staff, with a high death rate associated with it. This is terrible practice. This is the kind of practice that you would not allow to happen in global health in most settings. And here it's happening in a very sophisticated part of the United States, showing again this failure of the chronic care system. So when drawing on my own personal experience, when my wife, after 10 years of caring for her Alzheimer's disease, when she became, when I became unable to care for her any longer, she was becoming paralyzed and I couldn't lift her, etc. And she went to a very good nursing home. My adult children and I looked at 24 nursing homes in the Boston area. And 12 of them, half of them, were not just unacceptable, but they were appalling. They were appalling. Now, what made it possible for me to get adequate care for her, good care for her last 9 months, was that I had financial resources. Those 9 months in the nursing home for my wife cost me $200,000, $150,000 that I paid myself, and $50,000 that came from the fact that we were one of the few Americans who had long-term care insurance. The vast number of Americans do not have long-term care insurance. And so I think I've made the case that chronic illness, together with COVID, created havoc because of a broken healthcare system. Now, there are other things that took part in this. So part of it is the political domain and governance and leadership. On the East Coast, the Northeast, the governor of New York, Cuomo, and the governor of Massachusetts, Baker, were like the governor of California, good examples of attempting to quickly go to social distancing and all the things we associate now with isolation and quarantine. But in my country, which we think of as such a high-tech country, we had a disaster even for those leaders in testing, which reflected politics. So the Trump administration, one of the things it did when it came into power was to remove from Trump's security circle, where they have a a regular set of meetings about the major security problems facing the United States. They had a pandemic preparedness group. They were removed by Trump several years ago. And similarly, this administration has made political appointees who follow their interests, change the nature of some of our important institutions. So the CDC, the Centers for Disease Control, which has always been a leading institution in our response to epidemics, the CDC was injured by the Trump administration. They had key people were fired. They were put under greater political control. And the CDC, at the very beginning of this pandemic in America, made some very basic errors. They made errors in that rather than go along with the WHO testing kits, they said that they would only use their own, and sure enough, they produced a testing kit that was ineffective and that made mistakes. And it's taken them a long time, in fact, up to this date, to really be able to do the kind of massive testing that we require. So massive testing, case identification, case finding, isolation going with it, all of these things were delayed. And even today, it's only in a few states. One of them is my state, Massachusetts, where where we're getting to adequate testing and the use of case finding and of identification and isolation and quarantine. And that's because, interestingly enough, from a medical anthropology perspective, in the state of Massachusetts, the governor knows a former student of mine who was the former head of the World Bank, Jim Kim. And Jim, a medical anthropologist, suggested to the governor that Partners in Health, the NGO that Paul Farmer started, had the ability, from its work in West Africa with Ebola virus and with cholera in Haiti, to do the kind of case finding, identification, and isolation related to that required. And so that's happened in my state, and is one of the reasons why my state has done very well at this particular time. Now, very well is a relative term. Relative to places that have done spectacular well, like Australia, New Zealand, East Asia, my state still has problems. But compared to other states in the United States, we've done pretty well. If you look today at where the hotspots for COVID are in America, they're exactly in the places that the Trump administration has exerted the greatest political influence, and that's been an influence to play down the significance of the virus, its seriousness, and simple measures. So Trump has really done a terrible job, a failure of moral leadership. The fact that he doesn't wear a mask himself has given the message you don't have to wear a mask in this thing. And if we look at the places that opened up too soon in America, that never instituted the kind of policies I talked about, that have the most broken chronic care systems, they are in Florida, Texas, and Arizona. And that's where the hotspots are today. Now, from a medical anthropology standpoint, I mean, there are so many different questions that one could ask. Obviously, our contribution, as it were, is to get us into the lived experience of people. In this instance, the lived experience of families, the lived experience of patients, and the lived experiences of caregivers and policymakers. And I think in the United States right now, we have a fair amount of medical anthropological research going on in all of those domains. So, for example, I think we've had very interesting research in medical anthropology in the US on the experience of isolation, which speaks to the importance of resources, the role of racial injustice and of gender inequality. We see lots of interesting work being done today on the differential impact of isolation in poor communities. So if you look in Boston, there is a community, there are several communities outside of Boston, near suburbs, are called Chelsea and Revere. And those parts of Boston have the largest number of immigrants, have high levels of unemployed, have many people working on essential services, from working in grocery stores to delivery, et cetera. And they've had the most substantial effect in the Boston area of COVID. They've had terrible impacts of COVID. Research on, how could we not have research today given the intertwining of COVID and racial justice movement and our enormous attention today to gender inequalities? How could we not have attention to race? And we see the discrepancy, the tremendous discrepancy in statistics, looking at health inequalities and social inequalities. If you're poor and if you're Black or brown, this epidemic is much worse for you. And again, I think medical anthropologists have contributed to our understanding in that area. The fears and anxieties of health professionals on the front line. I have taught many health professionals, particularly physicians, over the last 50 years, and quite a number are at the front line. And I've been getting emails and telephone calls and other messages from them about the difficulty of being at the front line in America. And what we have seen, I think, is that in spite of inadequate personal protective equipment, in spite of insufficient number of ventilators and other kinds of equipment, of emergency rooms and ICUs being overrun, that the healthcare system has held up, its personnel has held up pretty well. And we're seeing now the beginnings of the long-term effects of that, which are in burnout, stress, anxiety, deep anxiety. And we can talk about that later on. Medical anthropology work has also looked at the experience of social isolation of the elderly in families or by themselves. And I think I've written a number of op-ed pieces in the Wall Street Journal on that topic. And again, resources loom large. Now, for the to get back to chronic care, the points that I made in my new book, The Soul of Care, is that chronic care is not just about the medical response, but is largely about self-care and family care. And in those areas of self-care and family care, certain things loom large. One is the quality of relationships. The evidence is where the quality of relationships in families, amongst friends, is strong, the family caregiving becomes both easier and more effective. And where those relationships are complicated or broken, the situation becomes more difficult. Second thing that we see is that resources are critical here. The resources that make it possible for someone like me to isolate at home. I have a big garden, if I showed you out here, where I can spend some of my time, a big house. I can order things online. I have the financial resources. Thank God, still the cognitive resources. I have the technologies surrounding me to make it, if not a pleasant experience, at least an endurable experience. But for people who have no resources, are in cramped quarters, can't get out, a very different situation. You know this from the situation in Italy. I think that from a medical anthropological perspective, again, presence is very important in chronic care. And again, that presence is the presence of the family caregiver and of the care recipient in the family. That presence is enhanced by things like social rituals, habits, the quality of the relationship, and the like. And it's a critical part of chronic care. The essence, if there is the essence, if we can use that term, of chronic care is actually the physical, emotional work of caregiving. And I think medical anthropology has learned a lot about this in recent times, and I've filled my book, The Soul of Care, with an understanding of it. The bathing, the feeding, the ambulating, the toileting, all those activities that one does for a family member who is disabled are the actual work of care. And they can be given in a mechanical way, even in a hurtful way, or they can be given with presence. And again, I think that research is bringing out the importance of that empathic, compassionate presence, what makes it feasible and what makes it difficult. Chronic care doesn't end with death. Our understanding of a healthcare system is wrong when we think that it ends with the death of the patient. There's a very important part of chronic care, which is the caring for memories. For the memories of the person who passed, who's died, for the way those memories are organized into, in a sense, embodied archives, the way that they are drawn on to tell stories that animate and help focus the way survivors, spouses, adult children, think after a death about a person who's passed. All of these things are critically important to the way that one gets on with the world in chronic care and family care. All of these areas have been touched by COVID and have been stressed made more difficult and troubled. And indeed, COVID has made it clearer to us why care is so central. Why care is not just about caregiving in its focused medical or family care sense, but it's about caring. It's about the acknowledgement and affirmation of the other from a moral perspective. There's a moral quality to care. And again, that has been affected during the time of this pandemic. One could go on about these things. They're well covered in my book. What I want to emphasize is, let me come back to the moral side of things. The subtitle of my book it's called, the title is The Soul of Care. The subtitle is the moral, I think it's the moral transformation, something like that. The moral education, that's it. The moral education of a husband and a doctor. And I tell the story of my own life, that I was raised in a well-to-do New York family and was a very unruly and undisciplined and wantonly careless child. I could be this way because it was a rich family who had other people like maids take care of me. And I began as a delinquent without any care in the way I lived my life, either caring for my room, myself, my clothes, my school. I became careless and also aggressive. And when relevant to the Italian framing of this meeting, I received my first compliments as a 12-year-old from the local mafia recruiter, who told me, Arthur, he said, I think he may have called me Arturo, we got our eyes on you. You're doing great, keep going. And that astonished my family and frightened them, and we moved to the suburbs where I channeled my aggressiveness into education and became a different person. But it was my wife who remade me. She remade a very aggressive, very tough, very self-centered person into a human being. And my mother, who lived to 102 and outlived my late wife, said to me just before Joan died from my wife died from her Alzheimer's, she said, Arthur, taking care of Joan has made you human. I think that it's that humanness in care that requires a transformation of who we are. That's what I wrote about, that's what I believe in, and that's what we see also in COVID times as being very troubled and difficult in the setting of a system, a chronic care system, a political system, a social system that seems broken. So to me, I was born in 1941 and socialized in the 40s and 50s. This period of time seems like a very broken period of time. My society is broken. Our healthcare system is broken. I think that medical anthropology today needs to contribute to the solutions. So let me make a statement on this point and then open it up to questions. This is a statement about medical anthropology, since you are a medical anthropology group. We've done a very good job in medical anthropology of critiquing the social, economic, and cultural systems around us. We've done a much poorer job in contributing to the solution frameworks for those systems. So we all are aware of the critiques of neoliberal capitalism, etc. But in point of fact, if we're not going to be in neoliberal capitalism, then what can we be in? There should be an anthropological contribution here. There has been some work, but we need more of it. 3 years ago, I think, or 4 years ago, I did a book with a colleague in England, Ian Wilkinson. The book was called A Passion for Society, How We Respond to Human Suffering. And in that book, we looked, Wilkinson, who's a sociologist, and I looked at the social sciences in relationship to social suffering. The pandemic is an example of social suffering. And we found that a series of critics at each age of the social sciences who pointed to its failures in contributing to society. So the origins of social science were great thinkers in Europe, principally, who made clear that the purpose of systematic social investigation was to improve people's lives and to improve society. The idea was to do something practical that would assist society based on developing a knowledge base about society. And then along came figures, many figures. Max Weber, for example. In my own country, Hannah Arendt, C. Wright Mills in America, Boas, etc. All of whom critiqued social science for failing to be as engaged as it should be in solutions, in coming up with solutions. We have this in anthropology today. We have created an anthropology filled with brilliant ideas, but no one reads it. No one outside of anthropology reads this work. We've organized anthropology as a kind of a game, a pastime for us, without having an influence in the world. And so Wilkinson and I critiqued that and looked at medical anthropology as one domain within which anthropology has had and is having an influence in the world. But even in this domain, I think, we've been limited, too limited in that influence. So there's no question in my mind that anthropologists need to be in every sector responding to COVID, responding to chronic illness, but they're not. They need to, anthropological knowledge needs to be used by people in these domains, but it is not. And so I've changed in my view of where do we publish. I refuse to publish now in narrow domains that are simply edited volumes or journal articles read only by a few. I'm trying to get out in the world with books, with op-ed pieces, with articles read by larger numbers of people in order to have some influence beyond anthropology, beyond medical anthropology. And I can't convey to you how important this is. So I belong to, one of the groups that I belong to is an academy called the American Academy of Arts and Sciences. It was founded by George Washington and by Samuel Adams, two early presidents of the United States. And it has about 3,000 American members and a few hundred foreign members. And it is a very elite organization, but it produces very important reports, crossing all the fields. So it goes all the way from academia, through the professions, through business, through the arts, through technology. And its reports get out to a wide variety of people. Well, we're having we've just had 2 meetings of a smaller group that was asked, charged by the president of the Academy to look into the post-COVID world. What will the post-COVID world look like? And I was the only member of that group, a very small group, maybe less than 15 people, coming from all the different fields. But I was the only person from anthropology. And I can tell you that if I could reproduce the ideas that that field represented, they would sound to you as anthropologists as really backward looking, not forward looking. Traditional ideas from political science that have little to do with the world that we're going into today. Ideas from the sciences and technology that seem to lack a social understanding of the world and how radically the world is shifting, etc. And again, it's a forum like that where we need to be effective. Now, I can tell you that I belong to that academy. I belong to this group. I gave it my ideas. They didn't pick up any of the ideas. Okay, so I'm not saying that medical anthropologists are necessarily going to be effective, but at least we should try. We've got to try. Okay, I think I've spoken extensively, and I've probably taken too much time. Let me now turn things over to you and to questions you want to ask. It's been a privilege and an honor to speak to you. Years ago, one of the first honors that I received was to be made an honorary member of the Italian Society of Psychosomatic Medicine. And so I've always looked upon that as an early and important example of looking more broadly in the world. Thank you for letting me present. Sorry, I'm having trouble hearing. I can't hear.
No, you certainly can hear us. We
Now you
Yeah.
can maybe.
our
Yes,
religious silence for your conference.
I still some problems with such a device, you know. Anyway, thank you to you very much, I was saying. Grazie in italiano. I say grazie a lei per questa brillante conferenza. Thank you very much for such a brilliant conference. And above all, for the last part in which you talk about medical anthropologist's duty in the contemporary world. Because this is, as Mariella Pandolfi told me in a talk during your talk we had, and thank you to Mariella the same, she told this is the first traumatic experience we had all over the world. And that is a fact that pushed medical anthropology to engage even so much than it did before to find solutions. And this is particularly interesting for us in Italy, because our master, our forgotten master, who was Tullio Seppilli, insisted for ages on the social use of medical anthropology. That is, he used to say to us, he usually taught us that medical anthropological knowledge should be used all over the world and also in the political arena. That is why, for instance, we appreciated, I think everybody appreciated so much, your critical references to the leadership in the USA. because populism now is a sort of medical populism. And this is clear all over the world after these pandemics. So thank you very much for that. And I'm sure that everybody wants to make questions to you. Everybody can book a question on the chat, and then I give the word to make the question, everybody. Thank you very much.
Gianni, can I interrupt?
Yes, of course. Mariella, let us see you. Let us see you.
See you, but it's not necessarily my voice.
Okay, we can also listen.
No, I can move it in. But Arthur, I think that in the last 10 years, really, you open a new space for the new era for medical anthropology. So, as usual, because in the last 30 years or 40 years, you open the space at one moment, and you engage a dialogue, a debate with all the world. And I was speaking with, not speaking, but by WhatsApp with Gianni, because I think that this is not the first pandemic in the world, of course, but this is the first moment with all people in the real time in globalized emotion, globalized fear. And this is a very intriguing moment to redefine theoretically what means that in the same moment, from one part, from the local part to another local part, humanity together spoke about fear, about virus, about the authorities, about the collapse of the health medical system. So this is a very intriguing. I just have this idea, but I don't know really. I don't know. I think that we have to think about this. This is for the anthropologist or for theoretical thought, it's a challenge. It's really an enormous challenge. And I think, so I don't know, that was a just, but of course, this idea came because you open a new space, you ask it for everybody. So another moment of the very important challenge in medical anthropology.
Yeah, thank you, Mariella, for that. That's, I think, a truly important insight that in this pandemic, for the first time, we see the lived experience of people all over the world, and everyone sees it. Wherever you are, you get the sense. And so we should think that one potential outcome of this would be greater democratization, a chance to hear all the different voices and to let them be more influential than they have been. But I wonder if that is actually going to happen. And so I think that here is again a important role for medical anthropology to take those voices and those experiences and to project them into a space where it can be understood how important they are and why they're important, that they democratize things, that they make institutions seem more remote and ask for new institutional developments, that they ask to hold leaders to account, that they bring attention back to the lived experience of suffering. I think that exploring this space, as you called it, a space, exploring this space should be something that medical anthropologists all over the world work at, with their attention to how now this global realm has brought the local up so that the local sees that the global is in the local everywhere. that a response in Lagos, Nigeria, is understood by someone in Boston, that someone in my favorite Italian town is Ravello. Someone in Ravello also knows what's happening in Beijing and sees this, that people are having similar responses. As you pointed to the issue of fear and anxiety, I think that's incredibly significant. So that challenges the very idea of what does security mean. In my new book, The Soul of Care, I argue at the end of the book, what would it mean if, from our understanding of the failure of chronic care systems, from our understanding of pandemics, what would it mean if we decided that the ethic of care and the responsibility of care was to become part of governance, so that leaders governing cities, governing regions, governing nations took care of the population seriously, made it one of the principles of governance, not the exercise of power simply to control people, but the exercise of power to make people flourish and to care for populations. Social care, as Hannah Arendt phrased that. What would it be if we rethought the security state from the standpoint of care? Then we would see that the surveilling the population has its limits and may actually be problematic. Then we see that taking the idea of care seriously would make health, social welfare, social inequalities the centerpiece of what we would regard as security. Take the economics. Supposing we were to demand a capitalism in which the contribution to people in society in terms of their care was critical to how capitalism was practiced. So I think there's a moment, and maybe it'll just be a window that quickly closes, I don't know. But there's a moment right now to try to have that global articulation. Now, I tried it at this American Academy of Arts and Sciences group with 13 or 14 other people from very different domains, and they didn't pick up on it, okay? But that doesn't mean that others like yourself and people attending this meeting can't be more effective at this. We need to keep pushing it, keep developing it. And I think we're in this very special time. And again, I would simply say, because I've seen so many of things happen like this, that this window will close. This window will close. So something needs to happen now, right now.
Thank you very much. There is a question from Cristiana Bastos. She can open the microphone and make the question, please. Thank you very much. You can open your microphone.
Can you hear me now?
Yes.
Thank you. Thank you very much. Thank you very much, Arthur. As usual, very inspiring. Thank you. My question, some of us have been around for a while and were witness of or participants in the AIDS epidemic, and we see many parallels, but now everything is time compressed, simultaneous. We know of the other part of the world instantly and so on. However, my question is, I have a feeling that back then we were expecting things to get better. Global institutions to build up together, face the problem, UNITES was put together, and Partners in Health, everything. And now I find a big difference on the distrust on global organizations, on the defunding, on the collapse of countries that used to be leaders. I see UK, I see US, I see Brazil, who led so much incredible responses to AIDS, and now is shame. So this is my understanding. It's not optimistic, it's worried. What
Yes.
are your feelings about this? What's your thinking? And you are also China specialist. What do you reflect by knowing so much of China and what's going on there now?
Yes. Thank you, Christiana. That's a wonderful set of questions. And whenever I see you, I think of Lisbon and how the wonderful times I've had in Lisboa with you. In the United States, the AIDS activist movement became a powerful moral force for change. And it changed many things. It changed the way that the Food and Drug Administration handled new medicines and studied them, and it made it much quicker process. It affected the way that my country thought of stigma and responded to stigma. It affected many, many things and was, in my view, the most important moral movement since the 90s. Now I think it's changed. I think it's not disease in America that is the focus of change. It is the Black Lives Matter movement, the protests for racial equality, and also the importance of gender equality. I think those have captured the sort of the moral space right now. And I'm somewhat optimistic about this in America. I think we're going to see some change. We'll see how big it is in the way that the criminal justice system is organized in the United States. Maybe that change will not be great enough, but I think it's going to come, and it may have to wait until Trump is defeated in November, as I'm sure he's going to be defeated, because I think that his failure of leadership, his complete immorality and amorality in this time has created a catastrophe for the United States, a disaster, okay? And I think Americans understand that. Now, global institutions, I'm with you on this. I think we need to rethink global institutions in light of COVID. And I think that includes the entire UN system and what it does. Just think about where it came. We should look first at the history. So it comes out of the Second World War, when at the end of the Second World War, the United States is literally a global hegemon, okay? It has all the power at the end of the Second World War. This is before the Soviets develop the hydrogen bomb and it becomes a Cold War. But before that, from 1945 to the early 50s, the United States had the major influence on rebuilding the global system. You remember, the United States never joined the League of Nations earlier, but it played a central role in creating the UN and that system. I think we have to rethink that whole system. That system, as I said again, came out of the dominance of the victors in the Second World War. Did not represent the world. Had colonialism and post-colonialism built into its very structures. Okay? So I think rethinking that UN system today is very, very important. And this begins, with the World Bank. Start with the World Bank and rethink the role of the neoliberal approach, which came to dominate economics, as my former student Salman Khashoggi, in his book on this subject, shows. That neoliberal system needs to be taken apart and remade. And that's why we need to redo I think, the UN system. I think the WHO is highly problematic in the way it functions today. In the areas that I know, mental health, tuberculosis, HIV, I'm not sure the WHO actually is a useful organization. Okay? In the pandemic, has the WHO been it's been useful, but not perhaps as useful as it should be. So I think we've got to rethink all this global structure. What will come of things? Now, here's where I'm pessimistic, because you can write a very pessimistic scenario of the post-COVID world. So China, the country I study, has made its goals first to surpass the United States in the next 10 years as the richest country in the world. No question in my mind that they're going to do that. They will do that. Secondly, that 10 years from now, they will have absolute military parity with the United States. That there'll be no difference militarily between the United States and China in terms of their power. Third, I think that China is showing us right now that it is orienting the world toward its interests. Some of those interests are very good interests, and I support. Many are not necessarily good. So what will that world look like when the dominant power is no longer the European community or the United States, but is China? Okay? And that's where we're going. That's my feeling is we're going there. Now, I think that makes global scholarship, global social science, humanities, scientific exchanges enormously significant. Because the great danger is that the relationship between the United States and China and Europe and China will become much more problematic. And what is going to keep a global set of relationships going under that pessimistic scenario is going to be a return to the role of the monasteries in 12th and 13th century Europe. Okay, that we will be the source of values and of knowledge that crosses the world. So that's a very pessimistic view in my view. Yeah. But at the minimum, we've got to have those connections. Okay, because if we lose those connections, then we're headed, it seems to me, ultimately to war or something equivalent to that. The second global issue, I think that's the existential issue for our time, is planetary health and environment and the catastrophe of global warming and environmental degradation. And everything we've tried to see done, has been inadequate on this one. And again, will a world in which China becomes the dominant force do better? I don't believe it. Okay, I don't think, because you look at China itself. What's going to help us in that regard? I think here, coming to see that all the things that we're interested in medical anthropology are also connected to environmental health, to planetary health, to what happens to in terms of global warming. All of this gives us an opportunity to bring health and environment together in ways we haven't done in the past. Now, are there global institutions that support that? I don't believe there are. I think that's what needs to be built in the future. Now let's take that, what I just said, and just sort of turn it on its head. Supposing it's wrong. Supposing I'm wrong on that. Supposing that China's influence does not become the dominant influence, but that we live in a world that is much more multicentric, in which Europe, Russia, India, China, the US, Brazil, Nigeria, Saudi Arabia, Iran, each have the same kind of influence. What will keep us, in terms of global structures, from recreating the biblical Tower of Babel in this setting? What will keep us from that inability to coordinate, to relate, to somehow bring together these very different sets of interests? And so even in a more positive scenario, because it's positive, it has the potential to see, say, democracy do better in the world. Even in that setting, there are big questions, and we don't have the right institutions in this. But I'm even more concerned, I think, with leadership than I am with institutions. Because I think, for example, that my country, America, has some very good institutions. It has some very good, but they've been completely obliterated by poor leadership, bad leadership, evil leadership, okay? And so I'm very concerned about leadership. Who are the leaders? How are they trained? What interests do they have? How can you make them moral leaders? How can you make them see that they're not just material leaders, they're moral leaders? And, you know, the interesting thing about Trump is, what is Trump? Is he simply amoral or immoral, and therefore a challenge to moral leadership of any kind that's good? Or is he actually a moral leader of a kind we don't want to have? Okay, so how do we even look at the moral? You remember in my book, What Really Matters, I suggested an anthropological view of the moral that was challenging. It said that the moral wasn't necessarily good. The moral simply was what was at stake for groups. And if people bought into that, what was at stake, they could participate in atrocities. Okay? Well, I think Trump is a leader like that. He's a leader like that. He actually does represent certain things. They're just terrible things, okay, that he represents. And he has a following. I forget, he has some incredible Twitter following in America. I think it's either 40 million or 60 million people follow him on Twitter. They're buying into this very negative moral energy and moral focus that he brings. So how do you combat that in the world? I think it has something to do with the training of leaders. And here, let me get to, because this is the only thing I find they have any kind of expertise on nowadays. Let me just get to the values, the issue of values in society. That we have not spent enough attention to the crucial role of values in society and how leadership must reflect and advance those values. And I think that what we've done is we've created a professional field of ethics that's simply taken ethics and moved it out of any significant role in the way we think of politics or in life itself. I think bringing value in society back as the central issue for leadership. What are the values of the leaders? What commitments have they made to values? This is why I'm arguing, and I know this can be seen as simply self-serving for a medical anthropologist. I've been arguing that care should become a central value in politics, in the political space. But maybe we need some even broader term that is less redolent of health, medicine, and illness. which after COVID may scare the pants of people all over the world. Maybe we need some other term for care. Whatever it is, it should be a central value in leadership. And how do we do that? How do we create that? How do we make it that? So I actually believe that this issue is a bigger issue than democracy, okay? I think democracy, in my own mind today, is filled with difficulties. I never thought I would say this. When I was young, I read a book by the great Spanish philosopher, Ortega y Gasset. And Ortega argued that he wrote a book called Mass Man, in which he argued against mass democracy and was picked up by the right in Spain. But he was actually a man of the center. He didn't want it to be that way. His critique was, what happens when there is a tyranny of the majority, when the minority cannot speak? And what happens when elite values that are good values, not bad elite values, not just the acquisition of money, but the acquisition of knowledge, the cultivation, aesthetic cultivation, cultivating yourself. What happens when those are just reduced to nothing, that they lose their significance? Can democracy in that way, he argued, be negative? And I think we're looking around the world. You'd have to say, boy, democracy has many failures. Now, usually we end up with what Churchill said about democracy, which is that it's a bad form of government, but everything else is worse, okay? But we need to think about, really, what is governmentality of the future? What is governance about? I think these are very fundamental questions, and they start with values. And we must insist, I think, on that, on values. And I think this is critical to medical anthropology. If we look at doctor-patient relationships in the world, and we say that acknowledgement and affirmation by the physician and nurse of the patient is the moral structure of the relationship. And then we look at telemedicine, and we see that telemedicine can be done without acknowledgement and without affirmation. And telemedicine now is thriving and may be seen as the medicine of the future. From a value standpoint, it's very problematical. From an efficiency standpoint, it's not. So, this is what I mean. And if you take that value seriously, the value seriously that I'm talking about, take care. It makes us realize that neither in Italy, nor in the United States, nor in Portugal, when we talk about quality care, we don't measure it. We don't measure it. What do we measure? We end up with institutional efficiency. That's our substitute measure for the quality of care, institutional efficiency. In order to really talk about quality care, we would have to make the moral and emotional and physical basis of caregiving what is measured. We don't measure it. Therefore, it's not represented. Therefore, it doesn't take place in the evaluations, etc. So I'm sorry for the long-winded talk, but you got me very stimulated. Thank you, Christiana.
Thank you, Christiana, and thank you, Arthur, for such a very insightful answer, very enlarging our problems. And I am sure that we can find even more suggestions in the following two answers. One from Pino Schirripa, who is a very influential anthropologist in Italy. He had been working in Africa. And the second one from Francesco Vacchiano, who used to work in an institution in Portugal,
Yes.
and now he's in Italy. You know him. Okay. Pino Schirripa, please. Thank you.
Okay. Can you hear me?
Yes.
Yes.
Okay, thank you very much, Professor Kleinman, for your talk. It was very, very interesting, and a lot of suggestions, of thoughts that for sure will allow us to better think about this pandemic. Then I would like just to make a consideration and a question. Consideration is that I agree with you about the room that is open for medical anthropology in this crisis. Also because I think that what this virus has put in the center is the idea that of broken boundaries. I mean, maybe than other times, between human beings, animals, environment in general, society. So we have, I think, new connections between humans and environment, between the idea of inequalities. Maybe it is too early to better discuss about it. Because as for me, at least, in Italy, I have the data about the deaths, about the people infected. But what we need is also to know the social status of these people, not only the age. And the geographical, not only in terms of region, but in terms of neighborhood, just to understand how it has been spread and where exactly. And maybe it can allow us to better discuss about inequalities, about nature, about environment. And I think that in this, we can have a very important role. Also because, as you said, from this crisis, we can just go out with a sort of what I would like to call political imagination, as in the second post-World War, in the post-Second World War, sorry. And we need that. And the idea to envision a new future where we can act. But in this, there is a question that I think, which is, are we ready for that? I mean, not as medical anthropologists. I need maybe also the policy makers. I just want to say one thing. If we look at, for example, at the literature on biosecurity, we know that we had some simulations of pandemic, both from nature or from terrorist attacks. And what is very astonishing for us is that anytime we know that WHO clearly said that our health system all over the world were not prepared to face a pandemic. And it was being said, for instance, in 2005, it means 15 years ago. But even though the neoliberal system keep on the same way, destroying the public health system, destroying the structures, the basic structures, destroying the primary health care. So my question is, how can we act in order to try to make a real change in this policy? Because I think that what this pandemic has shown us very clearly is that we need a U-turn to go back to primary health care, to go back to an idea of a spread health system, and not a sectorial one devoted to some 2 to 3 or 4 very important sickness. The idea of a global perspective about the health of the people, and the idea that health is a common good to be defended by everyone. Thank you very much.
Well, I agree with everything you said. It reminded me of Dante Alighieri when he says, how does he begin his great work? By saying, I found myself lost in midlife in the woods. I lost my way. I think we need to begin with that. That's what you're saying. We need to say we're lost right now. We lost our way. We're in midlife. We're older and we're lost our way. And what do we do? Where are we? How do we proceed forward? I think that sort of idea of ground zero, that we say some things, some institutions have to be rethought, and we got to rework them. It's not good enough just to talk about reform today or change. We start with the idea we're lost, that the societies seem broken, that the world seems broken, that we're in the woods and don't know which path to follow. I think that opens a space of rethinking. Now, I don't think that leaders of countries are going to say that, but I think as academics, we can say that, and that's the right thing to say academically, for us to rethink basic things like Christiana was suggesting, like the global structures around us. But this is the moment to rethink them and revitalize them. I think that's the goal. The goal is not to rethink them, to just criticize them and beat them up, but to revitalize them. So I'm with you entirely. I just that I think we should take time to think about how would we replace the system? What would we replace it with? What would we replace it with? So in my society, if we look at the way that capitalism functions in the United States, somewhere in the 1960s and 70s, American economists and leaders bought the idea that we should change the society from a manufacturing society to a service-oriented society. That was a huge shift in my country. And the consequences of that we still feel. If you go to the Middle West in the United States, you see the Rust Belt, the so-called Rust Belt, of cities that were the great manufacturing cities of America, with the rusted out plants and derelict spaces. And so we should rethink capitalism. I think a lot of people would like to do it. I happen to think that Thomas Piketty, the great French economist, has got some great ideas in this regard. That it isn't just getting parity in wages, it's the discrepancy in the accumulation of wealth that matters if you really want to have equality. I think that's a remarkable idea. I think the wonderful book that Ann Case and Angus Deaton in the United States have written about the epidemic of loneliness and despair amongst young and middle-aged white men who have not gone beyond high school education and who are dying at the highest rates in American society before COVID, and makes you rethink, how we do capitalism. So, I like this idea of sort of having a space for discussion and planning. But what happens, and what makes this so difficult, is that the practicalities of the world do not allow us much time to develop an alternative set of ideas and to put them out as policy. And so what we need to do is somehow get purchase on those aspects of revitalization of institutions that are critical. And I would begin with this idea that revitalization must begin with an idea of what values are prioritized. and that in the health domain, the central value cannot be institutional efficiency and economic cost. The central value in health must be care, must be care. And then how do you rebuild structures where care would be the central value? Anyway, thank you for provoking me, and that's my thought. Other questions?
Yes, and now it is the turn of Francesco. Yes, grazie, Francesco.
Thank you to you all to put this together. And Arthur, it's a great pleasure to see you again and listening to you. It's always inspiring, very much. Actually, I mean, I want to just to say things that are similar to what Pino raised about what are the lessons we can take from the pandemic, from the ongoing pandemic. And I mean, I agree that mostly what we have learned from the most affected areas, for example, Lombardy, northern Italy, is that a system unbalanced towards specialized intervention, specialistic care, hospitals. I mean, the healthcare system in that region has been reorganized across the last 20 years according to this kind of priorities, and neglecting more and more the proximity intervention, community care, etc. I mean, it is pretty clear about that area. I mean, that has undergone this kind of changes across the years, and and it's been more affected, and the failure of the system. I mean, it's not just a matter of not having a national health system. I mean, there is a national health system in that area, but it's a matter on how this system is very much organized there according to what priorities. And this is one point which, I mean, your claim to reinforce caring in parallel, I mean, together with curing, which has now to be neglected too, of course. But I mean, it resounds very much with our observation about the area, about what's ongoing there, and about a second consequence of the pandemic, which is economic crisis. I mean, it's pretty clear that it's opening up a wide and deep moment of period of economic uncertainties, to use an euphemism. So I mean, it is pretty clear that what you are saying is basically that we need welfare state. We need welfare that is able to intervene on every level in which the pandemic and the illnesses generally hits, which is the level of the body, but also the level of the community, the level of the family, and the level of the social reproduction, so the level of labor too, because this is pretty clear. I mean, in Italy, but in the United States too. I mean, in the US now, this is going to be a big concern, of course. So, I mean, we have the failure of the specialist-oriented intervention. We have a failure of thinking about the welfare state. And actually, according to your plea for more activity of medical anthropologists and from anthropologists at large, I would say that I've always found a lot of demand for anthropology and for what we had to say on the lower levels of, let's say, intervention. I mean, from professionals, from practitioners, from students for sure, but and every time I had the possibility to intervene on that level, there was a lot of respondences, you know, a lot of interest, and people found our contribution very inspiring and transformational too. But as soon as we started to climb a little bit the steps, I mean, a couple of steps further, and we tried to reach the organizational level, we always hit against the wall. And the wall, it was our system. The wall was how things must go. Ideologically, morally, I agree with you. I mean, neoliberalism is a moral view of society, which is very strong and very much rooted, deeply rooted today, you know. So, and deeply rooted within the mind of who's been organizing the healthcare system, the social system, the university too. So I would say we always hit against this wall, and actually also in this talk today we are eventually also going there. But I think that it's very important also to keep on doing it. I mean, you keep on reminding us how it's important and why it is so important to have this, and to think in terms of welfare state, and to think in, I would say, a systemic way of thinking, not just to the specific agents of a problem, but also to the larger impact of things, and how society is important. I mean, the care of society is important. I wanted, just the very last thing is about nature. I would say we were reminding, I don't know whether you agree or not about this, but I think that this pandemic reminded us that we are still made of nature somehow. A part of nature that had been neglected in us, our viruses, our bacteria, and the fact that, I mean, in the global north, it seems after the AIDS, that more or less this was had gotten under control somehow. And actually is not, this was a kind of awareness that is not like this. I mean, there were virologists who were warning us, have been warning us for years, take care, is coming back, is getting out. And we didn't want to listen to it, of course. I mean, it is a kind of a psychological process of denial, and a psychological process of return of the denied, I mean, of what we had dismissed. And I think whether in this point about nature and society, we can try to find a way out.
Thank you very much to Francesco. Thank you very much.
Sorry.
I have a proposal for Professor Kleinman.
Yeah.
I have two more questions. One, I am asked to read it, and another one, if there is time, is Alessandro Lupo, who wants to speak. So I can add to Francesco comment and the question.
Hold on 1 second. I've got to talk quickly, but
the first question made reading it. It is a question from Isa Lappalainen.
Thing, I'd probably be
Maybe you have read it, but I can read if you want.
I'll call you back later.
Okay,
Yeah.
I read from Isa Lappalainen. The question is, thank you for your very interesting talk, Professor Kleinman. In your and Wilkinson's book, A Passion for Society, which you just mentioned, you discussed Paul Slack's study on how religious beliefs about the cause and meaning of the plague in England gave rise to social actions that had the unintended consequence of promoting a more secular approach to managing epidemic outbreaks. What unintended consequences do you think we might see from the social actions and narratives prompted by the current pandemic? It is a question from Isa Lapolainen from Sweden. And after these two questions, long comment from Francesco and a red question from Lapolainen, I would give the word after, without speaking again, to Alessandro Lupo after your answer, Professor Kleinman. Thank you.
Yeah, I think that's good because I just heard from my assistant, I've got to deal with something in 10 minutes. Yeah, so, okay. You want to have another question? And I'll respond to them all.
I say you can answer, and then we give the word to Alessandro Lupo.
Okay.
But now you can answer to Francesco and to Isa Lapolainen.
Yeah. Okay, well, you know, Francesco makes many good points. He's a source of very good questions. And the first one is actually, the first part of his question is really about the structure of the healthcare system. And I can just tell you very briefly that one of the problems in China was that China does not have a primary care system. It's trying to have a primary care system. Hence, what China has is if you get seriously ill, you go to the major hospital and you go to the experts, and that overwhelms things very, very quickly. And you don't trust the local, you don't trust the primary care. So one of the things we've learned then is that China really has to build and they've learned this, a primary care system, and this is further evidence for it. The second thing is that in China, there's considerable distrust between doctors and patients, maybe more distrust than any other system I know of in the world. And doctors in China who used to emphasize that they were the third or fourth generation of doctors, now tell you, I would tell my children never to go into medicine, okay? So China has a real problem with the image of medicine, with the structure of medicine, and the response to it has been largely money. They're just pouring money into it. But I'm not sure the money is solving things. In the United States, we have a primary care system, but we have emphasized so much in terms of funding our high-tech tertiary care system that the importance of the chronic illness component of primary care has been has been limited, and that needs to be developed much more. So structures are important. What are you investing in healthcare, for sure? I think the nature thing, I tried to address that earlier. I like that idea very much. I think the idea that, you know, we're with the viruses. It's not that we're just all in this together as human beings. We're all in this together with the viruses, okay? And how do we replace ourselves in nature, with nature? And those are great questions. And I'm just reading a book, if anyone's interested in if likes novels. It's a wonderful American novel. It's called The Overstory, and it's about trees. It places people, human beings, amongst trees, and it sees the structure of the world as trees, the central structure, which means that instead of taking the views we have of a generation, 15 years, or a lifetime, 80 years, we should now be looking at hundreds of years from the perspective of trees that go on to live 500, 600, 700 years. It's quite an interesting, the stories are wonderful, but I'm with you on this point. Unintended consequences of social action. I believe strongly in that idea. When Robert Merton, the great American sociologist, developed the social theory of unintended consequences in the 1940s, he emphasized what he called the imperious immediacy of interest. The imperious immediacy of interest. That what blinds us to the potential negative consequences is that we're so focused on the present. We're so immediately focused present. So one of the unintended consequences from what we've talked about here is that we may be too COVID focused. That COVID's going to, has changed many things. It's going to be with us for perhaps a long while, but that we're too focused on the immediacy of the present to realize what are the longer term issues. And I'm with you on that. I think that's extraordinarily important. It has to do with environmental degradation, with human failures in medicine, with what you started at the very beginning in your introduction with, which was this idea of the where are the human sciences going? The sort of excision of the human sciences from the sciences. Where are they going? And so of all the groups of trainees that I've had, the group that makes me optimistic on this account are the MD PhDs, who have both medicine and anthropology. Okay? And I think that in the future, we're going to see the MD PhDs be a much bigger factor, not just for anthropology, but for sociology, for economics, for literature, etc. I think they're going to play a very big role, this bridging role. Well, I have to go now, so let me just thank you so much for this. You know, I'm a great admirer of Italy. Every year, I make myself read again Manzoni's La Promessa Sposa, okay? Because I so influenced my thinking. And it's wonderful to be together with you as the Italian Medical Anthropology Society, and I hope that the time will come when I can actually be in Italy again. Your country is such a remarkable country in so many ways, but the experience that you had of COVID has caught the world's attention, just as the United States experience is now catching the world's attention. And so we want to, you've had these sessions, and we in America want to hear more from what the Italian experience has been. And so please write that up and publish that in English, and so we can learn more from what you've gone through, what you've learned, etc. And for me, my last words are that I believe in medical anthropology in the world. I've worked in it for 50 years. I still believe in it. But I believe that medical anthropology has to rethink what its basic commitments are. And I think the advantage of COVID has been to make us see that we must maintain our criticism and our critical capacity. That's very important. But we must increase our efforts to be part of the solution framework. We must be part of the solution framework. So thank you very much.
Thank you, Professor Kleinman.
And since Alessandro ci sei, vuoi parlare oppure pensi ci sia poco?
Absolutely not. He has to go. We had a great time with him, and we need not say one more word. Thank you very, very much.
Thank you very much.
Looking forward to seeing you in Italy.
Looking forward to that.